Together we are strong. We will overcome. When we work together, we can accomplish anything.
As founder of Mass Together America, we are grateful to our expert advisor, Dr. Caitlin Sundling, for giving us the honor to be our guest speaker for a Q&A session at our Brace for Wave 2023 Town Hall gathering. A new wave started in the United States at the end of July, when school had not even started. In this new surge, we are alarmed by the steep rise in COVID hospitalizations and ER visits among children, especially in the youngest group. As children return to school, our team put together this town hall meeting because we need a place to share life-saving information and seek advice from experts. Our webinar series will continuously invite experts from different fields to talk about the latest scientific insights about SARS-CoV-2. Nearly 7 million deaths from COVID have been reported worldwide since the virus was detected. Among the billions of cases, an estimated 65 million already have long COVID, and each infection offers up a new opportunity to spin the long COVID roulette wheel. We hope what we will learn together will inspire more people to join the high-risk community in fighting for safer access in healthcare facilities, public transportation, workplaces, and school campuses by using all the tools to avoid getting sick. Tonight, at this Q&A session, we want to chat about outbreaks in nursing homes and hospitals and how to prevent them. How do you feel about your doctors and nurses barefaced or wearing a loose surgical mask around you? How do you feel about your doctor telling you that if you are wearing a mask, that you would be protected in a clinic where you are surrounded by people coughing, sneezing, having COVID-like symptoms? I don't know about you, but as an immunocompromised person, I feel violated, betrayed, and abandoned. My nephrologist wrote a letter to ask the rest of my medical team to mask up with me. I still need to beg for mercy during each doctor visit, unless masks are required at the facility. Each time, I need to tell these receptionists about the consequences I would face if I catch it again. Every flare-up will exacerbate the condition and advance the autoimmune disorder. Oh, but you won't die because you're still young, one specialist told me. They're only sympathetic when I told them that if I move to the next stage, the treatment is $130 per pill, 4 pills a day, and it won't be covered by my health insurance. Only then I was able to stop the unceasing gaslighting. To the high-risk community, politicizing mitigation is unacceptable. Not taking this wave seriously is unacceptable. Minimizing COVID openly is extremely discriminatory and unacceptable. Now, I will pass the mic back to Sarah Cahill, who is a coordinator of Mass Together America. Thank you, Sarah, for hosting for us.
Thank you, Julie. Distinguished guests, it is my privilege to introduce our esteemed speaker for today's Q&A session, Dr. Caitlin Sundling. Dr. Sundling is a remarkable physician, scientist, and pathologist hailing from Madison, Wisconsin, where I am also from. Her journey through academia and healthcare has been nothing short of exceptional. After obtaining her bachelor's degree in biochemistry and mathematics from the University of Wisconsin, she furthered her education as a graduate of the Medical Scientist Training Program, earning both an MD and a PhD in biophysics. Her dedication continued with a residency in anatomic and clinical pathology at the University of Wisconsin, followed by a cytopathology fellowship at Brigham and Women's Hospital in Boston. Dr. Sundling's expertise as a cytopathologist allows her to specialize in diagnosing cancer using small tissue or liquid samples, making her an invaluable asset in the field of medicine. Beyond her clinical work, she's a member of the World Health Network and the End Coronavirus Coalition. Her commitment to science and healthcare led her to join Mass Together America, where she lends her extensive scientific and medical knowledge to help individuals and communities better protect themselves during and after the COVID-19 pandemic. please join me in extending a warm welcome to Dr. Caitlin Sundling, whose dedication to both research and public health is truly commendable. So we have fielded some questions from our internet audience, and I'm going to start with those, but I would love if you have any questions for Dr. Sundling, please put them in the chat and I will get to them after we go through the questions that we got online. So please put any questions you have in the chat and I will keep track of those. So Dr. Sundling, thank you and welcome. Our first question is pretty basic. How can I get my doctor to wear a mask?
Yeah, this is a really important question. And I think the key thing is to know that you can ask. You shouldn't have to ask. It should be provided. I mean, this is basic infection control. But it can be effective to ask your providers to mask. And asking ahead of your appointment is a good idea. Some people have been facing pushback on getting doctors to mask, as Julie had described. And this is extremely disappointing and just hurtful to patients. And I think, but the next step then is there's a possibility to request masking as an ADA accommodation. And there are ways to go through with that. And I can share a couple of resources in the chat. There is not necessarily a one-size-fits-all solution. But I think really the key that people need to know is they can ask for masking, and doing things also like bringing masks with you can be helpful. All of these facilities have masks available, so that really, again, should not be necessary. It shouldn't be put on the patient to provide the infection control protections, but that can help make it a little bit easier. And sort of allay some of the concerns in certain situations. And of course, it's not just the doctor or the nurse that you're going to be seeing, but it's also, time in the waiting room and other places where there may be unmasked people. So it's really worth thinking about the entire approach and how you can make that entire visit safer. Is there a way that you can wait and have them text you to reduce the amount of time that you're in a shared waiting room, for example? Some ideas like that. That's just to get you started, but there are many ways to approach this, and it is worth asking for universal masking and other multi-layered protections to make the environment safer when you're getting medical care.
Thank you. And I know the People's CDC posted a guide to requesting accommodation. I used that guide. I had success with it at my primary care clinic. I've had less success with it other places, so your mileage may vary, but certainly worth looking into. At the very least, you can always write your providers prior to your visit and request that accommodation before you go in. Our next question is anyone currently tracking healthcare-associated infections?
So this is, unfortunately for COVID, not necessarily being tracked in the concerted way that it should. So I am not certain. With the end of the public health emergency, it looked like hospitals were no longer required to report COVID as a reportable condition. There's been a lot of confusion about this, and all I can say is it's not clear that there is required reporting of COVID infection as a hospital-acquired infection. Hospitals and healthcare systems have to report certain types of healthcare-acquired infections. And this is definitely something that is worth making your voice heard about on a national level. There are campaigns, for example, to let your elected officials know that tracking should be required, because how will we know if there's transmission in hospitals without tracking that? There is tracking in the context of research studies. So I was just looking at a research study that actually found of patients who were hospitalized with positive COVID tests, about 4% of them in that particular study had hospital onset. So they tested negative initially, and then after 7 days or more, they tested positive. So that is one way that we can get around this in a research setting, but it takes funding to do research as well. And that often is also supplied at a federal level. So it takes a lot of resources and infrastructure to do this. And it is incredibly important to know that people are being protected the way that they should be.
So we all know that COVID is an airborne virus, or at least a lot of us on this call probably know that, but do you know why, if it's an airborne virus, the hospitals are primarily providing surgical masks for their patients and staff as opposed to KN95s or N95 respirators?
I have personally asked or sort of been outraged by this question many times myself over the last couple of years, but that is a common issue. I will say that surgical masks do provide some protection, particularly source control. So if you are entering a healthcare setting and universal surgical masking is required, that is a better scenario than not having any masking at all. So if you are able to wear an N95 respirator and everyone else is wearing a surgical mask, then that's, not as bad. Of course, we wish that everyone were wearing higher quality respirators, N95 at least. But really, there's been a lot of confusion in recommendations about what should be done about COVID, whether COVID is airborne. We know now that COVID is airborne. This is not scientifically controversial in any way. However, some of those early ideas about droplet transmission have been difficult to dispel, and our public health authorities have not done enough to educate healthcare systems and healthcare practitioners to know what they need to do to protect staff and to protect patients. And that includes wearing, well-fitting respirators that really seal around the edges. We know that we need to do that for other airborne pathogens, such as tuberculosis. And I think this was mentioned just before the break. The CDC's HICPAC committee, that's their Healthcare Infection Control Committee, they are currently reviewing guidelines for infection control in healthcare settings, which include some concerning changes that might actually reduce protections in a broad variety of settings. So it's really important to, when you have opportunities to give public comment, even though not everyone in the room may feel they have expertise, as a member of the public and a person who is deeply affected by this pandemic, you should make your voice heard that airborne spread of COVID needs to be recognized, and we need to treat this as we do other airborne infectious diseases. And also recognizing that asymptomatic transmission is a significant problem, that we can't just count on identifying people with symptoms and then taking the precautions for those people. We need universal protections to have good infection control in this scenario.
If some people have a hard time wearing a mask, are there any ways they can protect themselves in a healthcare setting? Say if they have a skin allergy or they get nauseous wearing a mask.
There are a few things that can help. So the best one, which is going to sound a little bit over the top, but it really isn't. There's actually a special kind of respirator that is specifically for people who may not be able to get a good seal with a respirator or can't wear one for other reasons in occupational settings. So in healthcare settings, laboratory settings, et cetera, or when a higher level of protection is needed. And that's called a powered air purifying respirator. And that is the hooded respirator that has a fan filtered air blowing into it. That is not cheap. They run about $1,000, and but that is really the top level of respiratory protection that you could get, and it's really comfortable. It blows the air, the fresh, clean air on you, and so you don't get that resistance to breathing that you might get with a mask, which might be difficult for some people. So that's one option. It's not accessible for everybody. So the cost is a big thing. And the other thing is, if you're entering a healthcare setting, you might need to do something, like might need to have something done involving your face. So access to your face may be needed. So I really think, doing the best you can, a solution such as the Ready mask, which is a stick-on mask, that might not work for people with certain skin conditions, but that might work for people who have a lot of discomfort of feeling a tight mask on their face. So I think many of us have tried on many different kinds of respirators, and there are so many options out there. There honestly should be like a sampler. Some of the manufacturers do have sampler packs where you can try one of a few different types, but trying on different kinds until you find the one that works is helpful. But if you aren't able to find really the ideal mask, any mask that you can wear and wear comfortably is going to be better than not masking at all. So I think that's, and then having the other people around you mask in that setting is going to be protective, because there are medical procedures. Obviously, going to the dentist, you're not going to be able to wear a mask when you're receiving those services. Going to the ENT doctor, having, different types of surgical procedures, anesthesia, these sorts of things. We really rely on people around us to protect us when we're getting those kinds of procedures. So that's the other side of it.
Lisa was wondering, if you don't have any underlying disorders, can you still ask for masking as an ADA accommodation?
This is, I think, just worth considering that the definition of disability should not be considered in a really tight and exclusive manner. So requesting an ADA accommodation, of course, does not guarantee that you're going to get it, but know that many common chronic conditions like diabetes, being overweight, and even pregnancy, which really isn't an illness, but it's a common state that is for many of us. So there are a great many things that increase our risk of COVID, or of having a more severe COVID infection. So it's worth considering more broadly than thinking that you need to have a specific disability or a specific diagnosis to make that request. So I certainly think that I'm not a lawyer, so I can't really advise on the specifics of the details, and a lot of this does vary locally. But I'm going to put a link in the chat to a disability rights legal resource that is that will connect people with disability rights legal resources for their state, and these are free legal assistance resources that could help. So I would just say all of us need protection. All of us, by virtue of being human, are at risk of COVID infection, and the risks of the first infection or reinfection being a potential disabling event is really significant. So it is, all of us do need that protection. And so it's worth trying, whether that's through a formal ADA process or whether that's just a request. It is worth it. And when you make that request, it's not required that you have a specific immunocompromising condition or anything like that.
Not directly related to anything that we have been talking about so far, but I think you're the best person on the panel tonight to answer this question. Valerie would like to know when the optimum time is to get the latest COVID booster that's hopefully approved next week.
I think the optimum time is as soon as we can. So I'm going to try and get mine as soon as I can when those are available. I'm hoping I will be eligible. I hope that all of you will be eligible. As was mentioned earlier, just before the break, there is public comment that is still open today about vaccine access. This is still, not guaranteed to be sort of available for absolutely everybody, and it really should be. So yeah, I think that we are seeing an increase in COVID wastewater levels that's very significant right now. So things are really already underway. There's no need to wait and strategize. I think as soon as that's available, we should get it. And the other thing I would say about getting vaccinated, it's worth looking around to see if there is a safer vaccination site that you can find in your area. I know it's been tougher in my area to find curbside vaccination, and I'm really hoping that there might be an outdoor curbside option. But if you can combine it with another visit, or personally, last year I got my flu shot and my COVID shot at the same time, and that helped reduce my number of visits. That's not necessarily the right choice for everybody. Definitely check with your individual medical provider, or if you can get those shots at the same time, or if there's any reason you might want to space them out. But that is a perfectly valid approach that can help. So we're entering a heavy respiratory virus season. We're already seeing a rise in RSV cases. There is a new RSV vaccine that's available for older adults, and that is an exciting development as well that I would definitely recommend.
Thank you. And Lisa pointed out that Valerie's question may have also meant maybe she had COVID recently. If she had an infection, say in August, should she be rushing out to get the booster, or should she be waiting on that?
That is a great question. What I've been telling people, including my own family members who have faced these questions, we are seeing a lot of reinfections, and there are new variants circulating. So when you have a COVID infection, the antibodies from that might not protect against a new variant, and reinfection is just really common. So I would highly recommend, when you are recovered, feeling better and no longer contagious, I would recommend getting that booster as soon as you're eligible. So there's no reason to delay or wait. We are seeing reinfections. There's some misinformation about how soon reinfections can occur. They definitely can occur sooner than, sometimes something like a 3-month window is suggested, and we're definitely seeing reinfection sooner than that. So it is worth getting the updated vaccine as soon as you can, even if you have had COVID recently.
Perfect. Thank you for that. Michael had a question about HEPA filters. He went to get a PCR test, but due to funding cuts, they moved the test from a parking lot to a small indoor room. The staff weren't running the HEPA filter in the room because they said that the filter would stir up the air particles and make the risk worse, so they weren't going to run the filter until after their shift ended. He's asking if you have any understanding of that issue. He works in a classroom setting where he continuously runs a HEPA filter because that's what we're told is the best bet.
Yeah, that is really unfortunate. HEPA filters work really well. They filter at least 99.97% of particles that are of a relevant size for reducing the risk of COVID infection. And the idea that a HEPA filter would make it worse is just not true. It is worth paying attention to the airflow when you're kind of figuring out where to place your HEPA filter. But the air that's coming out of a HEPA filter is really, really quite clean, and makes the air safer in that space. So there's no reason not to run a HEPA filter in a room. And that's an unfortunate misunderstanding about how filtration works. So, and of course, masking in those spaces would additionally reduce the risk. So we can use HEPA filtration and masking together to reduce the risk even further. So I recommend HEPA filters. I'm to the point where now I have a portable HEPA air purifier in almost every room of the house. And when we've had wildfire smoke, or on the rare occasions when I've had to isolate because I had a higher risk exposure, we have run those HEPA air purifiers, and that should help reduce the risk significantly. So it's good that they had one. Too bad they weren't running it, and I wish they would.
Especially in a PCR testing facility. I mean, that's where people not only are going because they think they have COVID, but they likely have to pull down their mask to get tested. So really, creating a super spreader environment in a small room. Debbie would like to know if there's been any widespread discussion in healthcare organizations of promoting use of taking temperatures in ear or armpit instead of like an oral thermometer, so that patients wouldn't have to take a mask off.
I have heard people asking for that, and I have heard some good stories about when people requested masking, their healthcare providers masked, and they automatically went for one of those ear or forehead thermometers. So this is available. it's just worth considering, and it's also worth considering sometimes whether some of those components of the exam are necessary. If you're getting a medical visit because of something where there may be concern that you do have a fever, that is an important component of the exam. But otherwise, it is just worth having a conversation about what parts of the exam are needed so that you can reduce your risk.
Mike would like to know if you're able to talk about mask quality and efficacy. For example, he purchases N95s through Well Before, but are there ways that we can assess whether or not masks are properly constructed and fulfill aims related to filtration?
This is a great question, and I think it's really key because we've seen so many issues with counterfeit masks and other problems and just confusion and misunderstanding over masking throughout the course of the pandemic. One thing that I will say, just because I wanted to touch on it, for people who might be wearing a cloth mask on a regular basis, now would be a perfect time to upgrade. I really thank everyone who is masking, and this is a really good time to upgrade to a higher filtration mask, like a N95 respirator or a KN95 respirator from a reputable source. There are different types of masks available. So N95 is the US standard. So we have N95s that look, for example, like this. If I can show you, this is one example of an N95. They always have head straps. So N95s always have head straps. There is a higher level filtration, N100, and that's what I have here. This one has an exhalation valve. So when you wear an N100 with an exhalation valve, sometimes you may need to cover that. And this is actually what I wear for work, but I wear a surgical mask over it. Masking is no longer required at work, so I would be fine to not cover the exhalation valve, but I cover it anyway because it provides just another layer of protection, so I'm not exposing people, around me to my exhaled air as much. KN95 respirators have ear loops, and if you buy them from a vetted source, and as far as I've seen, Well Before looks like a good source for KN95s, that they have a very good filtration material. It's very similar to the filter material that's used in an N95 respirator. These are both really high filtration respirators. The KN95s, like I said, those have ear loops. If you buy your respirators from a well-regarded and reputable source, you generally don't have to worry about the quality. And I should mention one of the sources I really like is Project N95. And what I really like is that they have a wide variety of different options that are all vetted. So it can be a good place to start if you're looking to try something new and you're not really sure what would be a reputable vendor. So these respirators are always, the N95s and other, N100s are made to an occupational standard under a group called NIOSH. And that really guarantees the performance of the mask. The other thing is the fit of the mask. So fit is really important, getting a good seal around your face. So there are ways you can do a user fit and seal check, either by sucking in a bit of air and checking to see if you feel air and gaps around the edges, or blowing out, so that you can sort of check if there is any leak around the edge. And then, of course, there is fit testing. So fit testing is a little bit more cumbersome, but there are DIY options for people who are maybe a little bit more into the home science experiment and want to get an extra check if their respirator is fitting really well. So these are all really good options. Like I said, KN95s, KF94s, another international standard that if you buy those from a reputable vendor, you can be sure of what you're getting. N95s are the US standard, and those have very high performance. And the key thing is really, making sure it fits well to your face, wearing it consistently. And, of course, if you reuse your respirators, just check and make sure it's still fitting well when you put it back on, and replace it if it seems like it's not fitting as well as it used to.
Thank you. Kind of a follow-up related to that, Gata was asking, when you're purchasing a KN95 or an N95 with, knowing NIOSH standard is out there, Are there terms we should be looking for? Is there anything particular that you can look for to know this is like not a counterfeit? This is legit? Like, what are we looking for when we buy masks online?
My best advice really is to buy from a reputable vendor. Amazon has not done their due diligence in some of this, and they are an authorized vendor for certain N95s. But I just do urge people to be cautious, and I particularly would not buy KN95s from Amazon, but some people do have more information about how to vet the masks once they get them, and that just seems a little bit more difficult. So I definitely recommend buying from, a vendor that you know is good. So Project N95 is a good one. You can also buy from other distributors like, Home Depot actually has a large selection of N95 respirators. And they are, it's interesting because they tend to sell them more from an industrial standpoint, but they have a pretty good selection. I just think, you don't want to go looking for a deal on a website that you don't know. It's worth checking out and seeing if, if you're checking out a new site, find someone you trust who can say whether it's good or not. When I've had to look at KN95s and I didn't know, I would look at, for example, is this a vendor that's listed on Project N95? And then, kind of go from there. Really making sure that you're buying from a reputable vendor is the best way to check. Once you get the respirators, there are some sort of marks and things that you can check on the respirator, but it is more difficult because certain things can be faked. So it's more difficult to verify once you have the respirators in hand.
I do also want to give a little bit of a plug. This is not an official endorsement from Mask Together America. This is just Sarah Cahill, but I bought a FlowMask Pro after seeing it on Twitter, and it is a great option if you want an N95 that is reusable. You just can replace the filters after 20 hours for the everyday filter, 40 hours for the Pro filter. So I don't go out very much, so I've really only had to change the filter once or twice. And it's nice to not have to find more vendors. That being said, my husband has a larger face. He falls into the 10% of people that flow masks don't work for. So I also really recommend Project N95 just because they do have those sampler packs and you can find something if your face is larger or smaller. There might not be a one size fits all option that will work best for you. All right. Julie wanted to know, why or how does the virus spread so rapidly? And kind of connected to that, people can be infected but asymptomatic. And do we know what the percentage is of asymptomatic spread?
This virus has been very challenging because of how easily it spreads, and especially with new variants and immune evasion of new variants, it's been, tough to get ahead of. So this is, the virus does spread through the air, and the air is something that we just kind of take for granted in many situations. And so it's really requiring multiple layers of precautions to get the risk really low. And I think that's what I keep in mind when I'm making a plan for how to do something more safely. I want to take multiple precautions and not just rely on wearing a respirator. The respirator does work and it reduces the risk significantly. But if you get a little bit of a leak, as a healthcare professional, I've taken those fit tests, and when you speak, your mouth moves, and if you smile or move your face a little bit differently, you can get little gaps around the edges, and it's just kind of luck of the draw sometimes. You don't want to count on one layer of protection if you can add other layers. So universal masking is one way to do that. Air cleaning or doing things outdoors, that's another way to reduce the risk. And also making sure if you're getting together with people, that people might test ahead of time or at least monitor for symptoms and then not get together if we're having symptoms. But asymptomatic transmission is really fairly common, and that's one of the things. COVID does transmit both before symptoms develop and in some people without any symptoms at all. The most recent estimate I've seen is around 30% of people may not have symptoms with this infection, but it kind of depends how closely you look. And I think if you know anyone who's had a COVID infection, you know there's quite a spectrum. And particularly people who have had COVID in their household, they will see different people have different reactions to the virus. So one person may have relatively mild symptoms, whereas another person may have more severe symptoms. We aren't able to predict who's going to have the more severe impacts, but having no symptoms or really mild symptoms that might get mistaken for something else, like, allergies, or something like that, does cause people to not take the precautions they might otherwise take if they felt very ill. So that has made it much more difficult to control. And that's what makes our daily lives much higher risk, and our healthcare settings much higher risk, because we can't just count on isolating people who are coming in for respiratory infections, because not everyone has infections, and the workers themselves may have COVID without having any symptoms.
Sort of related to that, we probably have a wide spectrum of people represented in this group. Some people may have been frontline employees the whole time. For those people who are working in person, having to be around people regularly, knowing that rapid tests sometimes don't pick up on asymptomatic transmission, is there any kind of a protocol for how often someone who is regularly exposed to amounts of people should be rapid testing?
This is a really good question. And I think if rapid tests are freely available, there would be nothing wrong with taking one every day. Certainly that might not be practical for very many people. We're seeing a reduction in these resources, and many of us may have rapid tests left over, but there isn't as steady of a supply. So if we had free access to testing, frequent testing would definitely help, but we can't rely on that alone. As you said, the rapid tests are not picking up all cases, and particularly people who do not have symptoms are at a much higher risk of not testing positive on a rapid test, even though they may be infected and may be contagious. So a negative rapid test does not mean that you're in the clear and it's safe to gather without any other precautions. That's why I really encourage people to use multiple layers of precautions as you can. It's really kind of like add as many at the same time as you can. And testing is still really helpful, because when it's positive, it helps exclude that person. It helps that person isolate, keep from spreading to others. And it also helps that person take care of themselves so they can recover better. So testing is still important, but I would say this is one of the weaker precautions that we have these days. And though it certainly should be more available on a national level, we should have better testing resources, both rapid tests that can be done at home, as well as PCR testing, which I'm really seeing a decline in access to PCR testing, which is the higher sensitivity test that can really be helpful.
And just to throw out a quick note on that, someone in my still COVIDing local group was able to find that there are still like 3 or 4 community testing sites that do free PCRs in our area. Obviously, that's not going to be the case for everyone, but if you are looking for free PCR testing, there are usually your local health department's website is a good place to go for that if there are community sites still available. So definitely check into that, because that might still be an option in some places. Obviously, it's not going to be the case in everywhere. That's not grammar. It's not going to be the case everywhere. All right, I'm going to give you guys a 2-minute warning. If you have any final questions, throw them in the chat. Otherwise, we're getting close to the end of Dr. Caitlin's session here. Lisa would like to know if you can speak to the risk of outdoor events, not necessarily big events, but park gatherings, patio dining, that sort of thing.
The risk of outdoor activities is definitely lower than indoor activities. So I think if you kind of were thinking about the same type of event, doing it outdoors versus indoors, you definitely want to do that outdoors because the ventilation is basically nearly ideal in an outdoor setting, especially if there's a bit of a breeze. If the air is still, you can't really count on it. And I really like to draw on the cigarette smoke analogy. If there's not much of a breeze and you were outdoors, the cigarette smoke may still sort of hang around people. There is still a risk of COVID transmission outdoors, and especially with the current variants being highly contagious, we know people who have gotten COVID outdoors. And it's really important to still consider that there is a risk and you might want to take other precautions when you're gathering outdoors. So masking in an outdoor gathering is a good idea. I think it's a little bit of a mistake when we see, oh, you should mask in an outdoor gathering if it's crowded. Well, it's hard to know, is it crowded or not, and sometimes you don't know when you're planning, or you might not know until you get there whether it's going to be crowded. And there's also a lot of social pressure that, once you're there, you may or may not feel comfortable leaving. So I think taking those things into account, that you might want to take other layers of precaution even outdoors, such as having everybody mask, having people test ahead of time, making sure that people who have symptoms stay home, and that sort of thing can really help make outdoor gatherings safer. And it's just worth considering how many of those layers of precaution can you add to make your outdoor gathering safer and still enjoyable, and still allow people to see each other. So I think that's, outdoors is safer than indoors, but if you don't take into account the risk, I think it can be a little bit challenging, and it's worth taking those multi-layered precautions whenever people might be gathering and sharing air.
Thank you. I know even in my own state, we have the Minnesota State Fair pretty close by to me. Most of that is outdoors, and every year there's a major COVID surge after. So obviously it's not like walking down the street with 100,000 people, even if it's outside, is going to be completely safe or that safe at all. In terms of Paxlovid, Lisa would like to know, since early treatment is so vital, what steps do you recommend for ensuring that you get timely access to it?
Yeah, I think Paxlovid is a very important treatment for a COVID infection, and people should try to get Paxlovid if they are eligible. It not only reduces the risk of a severe acute infection, but it does reduce the risk of long COVID. The prescribing patterns for Paxlovid are extremely variable across the country and variable from one doctor to another. There are still, I believe, test to treat locations. So if you get a COVID test through one of those test to treat locations, you may be able to get Paxlovid through a pharmacy, for example, and through a pharmacist. It's worth looking to telehealth options as well, and kind of knowing what's available for your state, because I've noticed the resources really vary by state. And kind of knowing whether your individual medical provider would be willing to prescribe Paxlovid, or whether you might have to look into other options if that's not going to work out. And I do know people who've had to ask a couple of different providers in order to get Paxlovid, even though they had clear eligibility for that treatment. So I think it is worth advocating for yourself and trying to get that therapy, because it is very important if, despite your best efforts, you end up with a COVID infection.
Thank you. I wanted to make sure that we had a little bit of a break for everyone between Dr. Sundling and Dr. Levy, but I want to make sure, Dr. Sundling, if there's anything that you feel like we did not touch on tonight that you would like to, that you have the floor for a few minutes, if there's anything that you'd like to say.
I just wanted to thank you so much for having me. This is such a wonderful forum, and I was so glad to see so many people coming out in support of masking. masking in healthcare is incredibly important. It should not be something that we have to ask for. As a physician, I am extremely disappointed that more of my fellow physicians are not routinely masking, not only to protect their patients, but also to protect themselves. This is an ongoing pandemic that is having far-reaching implications in both acute infections, ongoing deaths, and long COVID. So I just appreciate everyone being here, taking the time to educate yourselves and doing what you can in your communities to advocate for better. It makes a big difference, and just look for where you can make an impact. So that impact may be within your own family, with your own medical providers, but you may be able to make an impact at higher levels too. That includes healthcare system leaders, using those patient surveys. If you get a survey about your satisfaction of your visit and you had a hard time getting people to mask, it is worth leaving that feedback, because this is really basic infection control. It's not an inconvenience on your providers. It's something they should already be doing to protect themselves. So whether that impact is at the healthcare system level or at a local, state, or national level, as far as elected officials, it's worth advocating for better healthcare protections to protect all of us. So I want to thank all of you for taking this time, and thank you, Sarah, and thank you, Julie, so much.
Thank you so much, Dr. Sundling. We really appreciate having you here. And I put a link in the chat a few times, but Dr. Sundling has a Discord channel for COVID precautions where she is very accessible and answers a lot of questions. Anytime someone has a new news article or a new study, she has a great insight on it. So if you're interested in that, please check in the chat for that invite. And we are going to take about a 10-minute break here, and then we will come back for Dr. John Levy's session. He's going to speak to us about environmental science in COVID prevention. And that's going to be a very great session. So please don't go anywhere. Take your 10-minute break, and then we will be right back. Thank you. All right, welcome back. And I will pass it over to Julie to introduce MTA.
As founder of Mastigate America, I'm excited to see all of you here at the Q&A session with Dr. John Levy. Tonight, we want to listen to our expert and learn about what needs to change from an environmental perspective in order to prevent the spread of airborne viruses. We encourage everyone to read Apoorva Madhavil's recent New York Times article, COVID Closed the Nation's Schools. Clean air can keep them open. To kick off this new wave, one school in Texas and 2 in Kentucky were forced to shut down. How can we prevent learning disruption and children missing school? How can we prevent people from missing work and worse, disruption to the supply chains? Rising heat and poor air quality caused by pollutants and airborne pathogens can exacerbate underlying conditions in people of all ages. Clean air dramatically reduced risk infections by 74% in a study of schools in Italy. A CDC study shows that air purifiers may decrease the exposure to viral-laden aerosols by 65%. The NIH has shared a meta-analysis published in 2022 about the asymptomatic infected individuals could cause rapid spread of COVID-19 among the population. Researchers found the pooled percentage of asymptomatic infection was 32.4% among individuals tested positive with Omicron variants. And young people, medium age below 20, had a higher percentage of asymptomatic infections. Studies have proved that the viral load from asymptomatic infected persons was similar to that of symptomatic persons. Knowing these facts, I really want to know what corporate America should be doing right now to stop this wave and more waves from coming. As an immunocompromised person, I'm tired of being forced to reject in-person gatherings and worry about unmasking for a sip of water on a plane. That's why I called Dr. Levy, who is an environmental expert, to help us understand the science and what tools an institution should be using to keep their employees and their patrons safe. With that said, I'm going to pass the mic back to Sarah.
Thank you, Julie. All right, distinguished guests, it is my distinct pleasure to introduce our speaker for today's Q&A session, Dr. John Levy. Dr. Levy holds the esteemed position of Professor and Chair of the Department of Environmental Health at the Boston University School of Public Health, where his exceptional academic journey and dedication to public health have made a profound impact. With a doctorate in environmental science and risk management from Harvard School of Public Health, his expertise is nothing short of exemplary. Dr. Levy's research is centered on the critical intersection of urban environmental exposure and health risk modeling, with a particular emphasis on understanding spatiotemporal exposure patterns and addressing environmental justice issues. His work spans a wide spectrum encompassing areas such as indoor and outdoor air pollution, climate change, and the profound impact of COVID-19. Most notably, Dr. Levy has played a pivotal role in co-directing the Center for Research on Environmental and Social Stressors in Housing Across the Life course. This interdisciplinary initiative delves into the realms of environmental epidemiology, exposure science, and health disparities modeling, aiming to unravel the intricate connections between chemical stressors, non-chemical stressors, social determinants of health, and their role in shaping health disparities across various stages of life. We are truly honored to have Dr. John Levy here today to share his profound insights and expertise with us. Please join me in extending a warm welcome to him. So, as with the other sessions, please drop your questions in the chat panel, and we will kind of alternate between questions that we fielded from our internet audience and questions that we're fielding from the chat. So please drop those whenever you think of them. And welcome, Dr. Levy. Our first question for you is, how can I get my kids' school to upgrade their filtration?
Yeah, so first, thanks for the kind introduction. Yeah, and it's wonderful to be here. I know a lot of people have many other things to do on a Friday evening, but this is such an important topic, and it's great to see this convening. So in terms of thinking about schools and filtration, as well as ventilation, I kind of put them both into that same broad bucket. Yeah, I think Julie touched on some of the really important points to start with, right? Starting by really appealing to the goals of a school, right? Why do we have a school? We hopefully all can agree, whether we're parents, teachers, administrators, that schools are there to educate children, and that to educate children, we want them in school as much as possible and in a position where they can learn as well as possible. So an investment in filtration or in ventilation, an investment in clean indoor air is actually an investment in learning. If the kids are absent or the teacher is absent because they're sick, or if we have, as we've seen in recent days with some of the incredible heat waves, kids can't even concentrate if the school is open because it's so hot, they are not learning. And so then that is against the mission of the school, and the school will not be successful. So we really need to think about these mitigation strategies. Of course, centering COVID, that's why we're all here. This is incredibly important rationale. But for many schools, putting it into the broader context that, again, this is an investment in well-being of families, an investment in their health and their ability of the parents to go to work, and an investment in learning, just as any other investment a school would make would be an investment in learning. I'm not an economist and have not sort of followed all the ins and outs of the various bills, but I've certainly seen that there's a lot of ESSER funds that have been deployed to states for schools to upgrade their facilities that have not yet been expended. I know some of those funds have been expended on really important things like tutoring and other things that to address learning loss. But these kind of structural improvements to buildings are really long-lasting, profound impacts that can help, year after year, generation after generation of kids to learn quite a bit better. So, I would hope that the pitch could be made to many schools. Some probably have COVID more front of mind, some have pushed it to the back of mind, but really reorienting our thinking around schools as a place where we really want to invest in the healthiest indoor spaces we possibly can to promote learning for kids K through 12 and beyond.
If someone is sick in their home, what is the best kind of filtration to use to protect the rest of the household?
I mean, if someone's sick in the home, you really want to use as many layers as you have available, right? I think that, we've learned that over the years, and that's sort of classic, environmental health, occupational health, to utilize these layers, the so-called Swiss cheese model. And so you certainly want to start with, if you have an HVAC system, like with central air, having as high a MERV rating as you can accommodate within that. A lot of homes don't have that capacity or the ability to do that. There's no central air, or you can't put that great of a filter in. Portable HEPA really does a fantastic job. There's a lot out there to buy, and it can be very confusing. There's things with a lot of bells and whistles, but you don't need the bells and whistles in this case, things that are saying that they have some fancy chemical or ozonation or all that. Ignore those. You just want something with a good filter that's going to pull the right amount of air through it. I think people may have read or heard about Corsi Rosenthal boxes, which is probably the best manifestation of that. It's just a simple bunch of box fans or duct taped together with filters. It can be built at home, relatively low cost, and it's just pulling the air through, pulling it through a very good filter and cleaning that air. And so you can achieve that a lot of different ways. Again, the key is to have something that is sized to the room, and then you're really cleaning that out. Everything else is really kind of the basics. If you're fortunate enough to have a large enough home, you can keep the person who's sick as far away from possible as other folks. If people can wear masks inside the home anytime they're close and interacting, that adds another layer. So again, it's about getting your ventilation, getting filtration either house-wide or targeted with some of these portable HEPA, and then using as many other layers as possible to try to keep the other folks in the household healthy.
Thank you. We had a question earlier for Dr. Sundling, and it seems like something that might be up your alley a little bit more. So one of the gentlemen in our chat, Michael, went to get a PCR test, but they moved the testing site from a parking lot into a small indoor room. And the staff in the room said that they weren't going to run the HEPA filter until after their shift ended because they didn't want to stir up the particles and make the risk worse. So what is your understanding of that as a mitigation strategy? Is that effective?
I mean, that strikes me as a bad idea. The kind of particles that we're talking about, for SARS-CoV-2 or a lot of these other very small particles, right? The reason we worry about them in indoor spaces is that they can stay suspended in the air for quite some time because they're very small. Once they land on a surface and deposit, they don't really have the ability to resuspend in the same way. They sort of agglomerate onto each other. They get bigger. They're not going to magically take off again. And so you're worried about things that are in the air and lingering in the air because they're very small in size, not the things that have already landed on the ground. So, the people unfortunately talking to Michael were wrong. They should be running the HEPA filter when anyone who could be a source of COVID is in the room, running it for a little while afterwards because things can linger in the air, and so you want to keep that air flowing and keep it filtered and ventilated for a little while. If you have a right-sized HEPA filter, you might be good to go, 15 minutes after the last person has left the room. It could be longer depending on the size of the space and the kind of filtration. But, after that point, you can turn it off, not turn it on. So I think their advice was about the opposite of what you'd want to do in that circumstance.
That was what Dr. Sundling thought as well, but we wanted to ask you too.
Mm-hmm.
So we know that you specialize in advocating for engineering controls. If you are in a space where you know that the ventilation is good, do you still think that you should wear a mask?
I think the answer is it depends, which is not a very satisfactory answer. But, in the extreme case, if you're in an outdoor setting, which obviously is the best ventilated setting you can get to, and it's a relatively uncrowded space, you're not jammed up against a lot of people, you can forego a mask because you have the power of dispersion on your side. If you're at an outdoor concert and you're kind of shoulder to shoulder with thousands of people, you probably want to wear that mask, right? Because you've lost a little bit of that ability of things to disperse and spread out. And it's the same story if you're in a small indoor space. Ventilation can do quite a bit. Ventilation and filtration can do quite a bit. But a lot of times what that is addressing is sort of the room-wide impacts, right? The aerosols that are circulating in the room and trying to remove those out. If there's someone who's 3 feet away from you who has COVID and they're breathing in your face, the ventilation system isn't going to fix that, right? That's sort of kind of that immediate source impact. So, it depends on the setting and circumstance. Again, the more ventilation you have and the more it's like an outdoor setting, the more comfortable you can be with the mask off. But it's a matter of judgment. I saw actually, Jeremy Faust, folks may know him, writes a lot on COVID and wrote a very, I thought, thoughtful piece in recent days, just talking about some of his recent excursions and how, he had his mask off in some settings, put it on when he went into a bathroom, took it off when he was at an outdoor space. And I may not have done all the exact things he would have done, but I think I appreciated that philosophy of saying, all right, let's be thoughtful about the size of the space, the nature of the ventilation, who's in that room, and certainly utilize the mask when it's most important to do so.
And I just put a link in the chat to that article if anyone wants to check it out. Jeremy Faust runs a Substack called Inside Medicine, and someone also from the news interviewed him based on his Substack and wrote an article called 3 Places an ER Doctor Still Wears His Mask to Protect Against COVID. So that link is in the chat if you'd like to check that out. Our next question is, what would your advice be for the father whose asthmatic daughter was called out and forced to unmask in the school in San Antonio, who wore it to protect herself and her sister with cancer? What would you do if the principal asked your daughter to wear a tag so the teacher would give permission for wearing a mask?
Yeah, so that's horrible at a lot of different levels. Again, it's very difficult to know how to respond in that circumstance. I'm not quite sure if I would have been able to hold my temper if something like that had happened to my family. I don't know if I have brilliant insights on how to respond in that situation, other than to reinforce the obvious that wearing a mask is not a scarlet letter, in spite of what some folks have said in the past. It's a smart mitigation strategy that people can choose to do. And it's something where it should not be anybody's business why someone chooses to wear a mask. It could be because they're asthmatic, or they have a sibling with cancer, or they live with a grandparent who's vulnerable, or they just don't want to get COVID, which is an entirely reasonable reason to wear a mask. And so I don't think reasons need to be articulated or interrogated in that manner. I would, again, come back personally to the values that hopefully any principal or educator would have, which is that we want to be an inclusive and welcoming space for all kids, and that we never want to single out a kid for any attribute that they have, whether it's, physical, emotional, anything else. And so the idea of tagging a kid because to say, hey, my family has this certain circumstance just seems wrong in about 20 different ways.
Agreed. And also, if you're the only kid wearing a mask in school, kids are mean. It's maybe not the nicest way to put that, but you're singling that kid out to be bullied, it feels like.
Yeah. And the other point just to make, again, in an era where clearly we are not in a universal masking era, and so many kids like that are the only one or one of the only ones in their class masking, they have an enhanced need to have that protection, right? We all know that universal masking is far more protective than individual masking. You get that multiplicative effect. And so if nobody else around you is masking and people are not testing and so forth, it becomes that much more incumbent on someone who is at higher risk to use the tools that they have to protect themselves. And so again, the balance keeps shifting in a way that is very uncomfortable, where a smaller number of people need to do more and more to protect themselves because other folks are doing less and less.
Yes, that was my particular reasoning for upgrading my mask last year. Was we're in a spot where universal masking isn't a thing, so I need to be wearing a better mask. New York created 2 bills to require the city to create standards to measure, monitor, report, and enforce air quality inside schools and municipal buildings. Do you think there should be any laws for indoor air so buildings will be more accessible for people with medical conditions and disabilities?
I think that's where there's a lot of opportunity to do something that would really make a difference. I think there's momentum toward actually regulating indoor air that has never happened before and really hasn't been talked about anywhere near this scale for a very long time. And so I think this certainly has come to the forefront because of COVID. But as mentioned earlier, it's not the only reason that we want to have good indoor air. There's a lot of reasons that we want to do that, and a lot of historical reasons that we haven't taken those steps. And there's certainly a lot of challenges in trying to regulate indoor air. There's substantial barriers. There's actually a group out of Johns Hopkins that recently put out something they call the Model State Indoor Air Quality Act. So they're trying to give sort of the information and structure for states to have a legal framework that they could use to try to address indoor air quality. Again, given all the complexities and issues of private property and so forth, gave them a legal architecture that they could utilize that was broad enough to sort of fit the particularities of any one state versus another. And in the report, when they put it out in mid-August, they mentioned that in the last year, there have been 500 bills put out at the state level related to indoor air quality regulations. So I think there is a lot of momentum. I just saw Julie's comment in the chat that with wildfires, we've also recognized the importance of filtration and ventilation and trying to have safe and clean indoor spaces. So I think we are really at the cusp of doing something that can, again, recognize the importance of the place where we spend 80 to 90% of our time, and certainly schools, offices, municipal buildings, places where you want people to be healthy and productive. It makes sense to try to have as good air quality as possible. Again, there are a lot of complexities there, but the framework that Johns Hopkins put forward, other measures that have already been happening at the state level, I think really give an exciting path forward, which is, a blend of, utilizing monitoring where possible. There's, of course, many buildings in the world, and it's difficult to measure in all of them, but a strategy where you can take measurements at a defined amount of time, use that information to decide what kind of mitigation strategies might be needed, to incentivize, and I think this was an important part of the Johns Hopkins proposal, incentivize building owners to do it themselves, to sort of avoid the possibility of having the state come in and have to do it. So if you're incentivized to take your own measurements and do mitigation, put one of those things up in the window like we've seen for food sanitation quality, like you get an A, you get a B. If you're incentivized to you can put a sticker in your window that says, I have A air quality, that can again, be an inducement for people to come in and utilize your facility. So I'm not overly, I don't want to say overly optimistic, because these things are challenging and sometimes die on the vine, but I'm more optimistic than I've ever been that we might actually be able to do something on indoor air.
Sweet. I'm optimistic too, and it's nice to have someone back up my personal sense of optimism with knowledge of the actual scenario that we're living through. So that's cool. Derek has a question in the chat. He wanted to know, the CDC website talks about like directing fan discharge towards an unoccupied corner and wall spaces or up above the occupied zone, avoiding the use of high-speed settings and taking care to minimize the potential to create air patterns that flow directly across one person onto another. Would this apply also to portable HEPA filters?
I mean, I think the short answer is that it can. It's a little complicated. I don't know that I would say avoid the use of the high-speed settings on your HEPA filters, because that's what gets that maximum. When you buy them, it has that CADR rating, CADR, that kind of tells you how much air flow and air filtration you're getting. And a lot of times that's based on the highest speed setting. So you want to make sure that you're getting as much oomph as possible. But it's certainly true if you are pulling a substantial amount of air through, you need to think about how having that in the room is influencing the airflow. Now the good thing about a HEPA filter versus a fan, right, is that the air that you're pulling through is coming out the other side cleaner, right, versus a fan that could just be blowing air from one spot to the other and not doing anything. So, it's not exactly the same, but you want to certainly be thoughtful about where you put your HEPA filter, to ensure that you're actually capturing the air in the room that you're trying to capture, and that it's moving through the space in a logical way that then is hopefully getting vented to the outdoors.
Desiree would like to know, she's seen an N95 mask recycling program in the US and she's full-time masking, but is there an intersection with sustainable earth caretaking and masking for our caretaking? Like, are recycling masks a legitimate option for this? Like, what are the environmental impacts of the disposable masks?
Yeah, but it's a really good question. I don't know the answer to that question. I mean, certainly that is something that's been raised on many occasions, maybe to counter, people wearing masks, is that it creates an environmental burden. The ability to recycle them would be fantastic. Again, I don't know offhand how viable that is given the combination of materials and what resources there would be. But hopefully there is someone out there thinking about even, building a mask that could then be recycled at the back end. I mean, you certainly don't want anything that would compromise the integrity of the mask itself or the ability for it to perform its task, but some ability to try to, deal with the waste issue on the back end would be helpful. I mean, one other thing I'd say, which is not, Desiree, terribly related to your question, but it just comes to mind, is that, right, with some of these masks like N95s, right, they can be worn many times, and I feel like that's one of the advantages, both financial, logistic, recycling, anything else, versus kind of one and done masks, right? If an N95 you can wear on many occasions, usually until the straps get really loose or snap or degrade, as long as you just kind of take them and hang them up when you're done with them and don't crumple them up. And so you at least create a lot less waste by reusing, which is always kind of one of those, three tenets of recycling. So hopefully if you're not disposing of as many masks, you're reducing the problem a little bit.
And I did just want to point out again, Mask Together America does not endorse any mask brands, but Sarah Cahill bought a flow mask last fall specifically for that reason. I didn't like that I was still throwing away KN95s on a regular basis. And the pro filters on these last for 40 hours. So potentially, unfortunately, the filter is not recyclable, but if you're throwing away a smaller object every 40 hours versus getting rid of a KN95 every day, you are kind of creating a much less, a smaller footprint on your landfill doing it that way. So that was why I upgraded to a flow mask, specifically because I really didn't want to be throwing away a mask every time I used one. So
Yeah.
that is potentially an option.
Yeah, really good point.
Debbie wanted to know if there is anyone in Congress who has taken up the issue of indoor air quality seriously.
It's a good question. I mean, as I mentioned before, a lot has been happening in the states. Here I'm from Massachusetts, and I know multiple state senators that have really taken up the cause of indoor air quality, put bills forward at the state level. So there's a lot more happening at the states. I can't think offhand of people who've really been at the vanguard at the federal level. It's also something where, and again, I'm not a legal scholar by any means or kind of astute on the political side of things, but it does seem like action at the state or local level is much more likely than at the federal level, right? EPA, hasn't really put forward new regulations or new regulatory structures in a generation or more. And so thinking of, there have been some folks who've written quite eloquently about how EPA should think about, just like we have an act for outdoor air pollution, that there should be a new indoor air pollution act that EPA would put forward. I don't see in the current political climate that happening anytime soon. And so I've at least put more of my mental focus on what can states do, what can cities do, what can local towns do to advance, regulations or measures that would support clean indoor air in the buildings that they they have in their communities.
Thank you for that. What are some questions that parents could ask their school to find out if they have adequate ventilation?
Yeah, no, it's a really good question. I mean, I think you want to ask certainly if the HVAC system has been serviced or upgraded at any point. I think you'd love to see a measurement of CO2 or measurements of CO2 taken in occupied classroom spaces that can kind of give a sense of whether ventilation systems are actually working as intended on the ground. I think you could have, fantastic ventilation systems, staff who've really tried to do a great job. And then sometimes the air distribution is not uniform, right? You could have one classroom where things look great, and then down the hall it looks lousy for a host of different reasons. So I think you ideally would want to have data that can try to reinforce that. And then there's, of course, two sides of the coin. Is the ventilation side and the filtration side. The filtration side, that it's more of a direct question in some ways of, do you have a MERV 13 filter or something anywhere close to that in the HVAC system? Do you have portable HEPAs in any of the rooms where it seems like it's not being adequately reached, or if you, for some reason, aren't able to put in the MERV 13 filter? Again, some systems just can't accommodate it. So, again, you want to see specifics, and you want to see data, or at least see that, there's not, parents can't be expected to be experts on all different parameters. At least see that the building managers and superintendents and other folks have been collecting and looking at the data to try to figure out what actions to take.
Thank you. Julie and Lisa both had very similar questions about installing like a far UV light system. If you're using a UV light system in a room, does that kind of create a COVID safe room? Is it creating a safer room? Is it a good solution in a high risk setting or restaurant or a place where people gather?
Yeah, it's a really good question. I'm not an expert on that technology specifically. I know that there are a lot of folks who are experts who really swear by it and utilize it. It does have a profound ability to kind of, deactivate viruses and other nasties in the air. I know, one person, Don Milton, who's an expert on bioaerosols. And I know that when he travels to airports, or at least a couple of years ago when he was traveling to airports, he had his own little kind of UV system that he set up. And only once that was running did he feel comfortable taking off his mask and kind of his zone covered by the UV. And so I do think that does quite a lot and can kind of create a safe zone. It's obviously not a universal strategy because you can't have that every place, but certainly in high risk settings, it can do quite a lot and could be very beneficial.
It's interesting. My aunt and uncle actually installed it in their house and used that to try to get us to come over for dinner. And I wasn't sure about that, so we haven't gone over for dinner with them. But just the fact that they were interested in installing that in their house, I was like, they're probably like-minded enough that they're safe. But
yeah, it's a real thing. It's not one of these sort of like bogus, buy for $29.95 on late night TV commercials thing. I mean, it's a real legitimate scientifically proven method that does work for a range of bioaerosols.
Sue would like to know, how can you kind of control mitigations when you are in a car? So for example, if you're parked, someone comes up to your window, is there a way that you could handle that without getting outside air in? And also, if you're sharing a car with someone who might be infectious, is there an optimal way to seat people? Is there an optimal way to have the windows open? There's a lot of kind of conflicting information on the internet about that.
Yeah, I mean, I'd say certainly, right, if you're in the car with someone, obviously wearing a mask is a good thing. You don't want to be in recirculated air, right? Because that's where you're just rebreathing the same air over and over again. So you don't want to be in a windows up, recirculated air. You want to be, venting air, bringing air in and then pulling air out. Pulling down some windows makes sense. I know that as you're driving, airflow can get kind of complicated. yeah, I don't know offhand, if there's an optimal seating configuration, right? Intuition would say it's probably better to be front seat, back seat than side to side. And again, I think having the air kind of flowing out of the vehicle as readily as possible, which, in a 95-degree day, you might be wanting to be on recirculate, run the AC, but that's, really gonna, again, rebreathe the same air over and over again and contribute to higher infection risk.
Thank you for that. If you're getting medical work done outdoors, like dental hygiene, is it useful to have a portable fan behind the facing person, or is outdoor close contact safe enough? Does it make sense to have a true HEPA air filter on, like under your mouth or on your side when you're outside versus like if you're inside a dentist's office?
Yeah, it's a good question. I mean, again, all of these things are a matter of degrees, right? You wouldn't want to say that just because you are outdoors, the risk has immediately gone to zero, right? The risk has gone down, but if you're in close proximity to someone for an extended period outdoors, right, there is still some risk. Whether it makes sense to utilize a fan or, portable HEPA, I think it really depends on exactly what that is doing for air movement, like which direction it's moving it, if it's able to really pull things away. I mean, again, intuitively, if the dentist is right there by your mouth, as they kind of have to be, right, it's not clear that any of these systems would completely, obviate the risk, because it's just nothing can yank all the air parcels away that quickly. And if you're, I would certainly be far more comfortable in an outdoor space, if the dentist were wearing a mask herself. Again, whether these other strategies would work probably depends on the somewhat, idiosyncratic configuration of any one setting and which way the wind is blowing and so on. That's a little harder to tell.
As an aside, if any of you have a local still COVIDing group on Facebook, those are recommended. I saw someone in my local group today posted about a dentist in our area who is still requiring mitigations. So if you are looking for that sort of thing, it can be helpful to talk to other people in your area about where they're going. Dr. Levy, do you have any advice for parents who want to advocate for ventilation at their schools but might be getting shut down or not taken seriously by their schools? Is there anything they can do to kind of push for that?
Yeah, I mean, I'd come back to, I think, something I'd said earlier, which is, right, to speak the school's language, right, and acknowledge that, again, for better or for worse, I'd argue for worse, like in many school districts and in many settings, people have put COVID in the rearview mirror and approaching them and saying you need additional COVID mitigations may not be politically viable, but saying, hey, you know what, we need to make the healthiest space for our kids. We know you're worried about test scores. We're worried about test scores. We're worried about learning loss from the pandemic. And there's been a lot of evidence that kids do worse on tests in poorly ventilated spaces. So let's try to figure out strategies by which we can have our kids in the best learning environment possible. Also making the case, of course, that we want to reduce absenteeism, keep kids healthy and in school and teachers healthy and in school. But, just making that case that a well-ventilated indoor space is just an intrinsically good thing in a school setting. And then it comes to the discussion of how you do it, right? I think if you can make the case, and some principals would like to see data and some would believe you and some wouldn't, but, I think if you can make the case, all right, if we can all agree that we want a well-ventilated indoor space where the temperature is comfortable all the time. We could probably all agree that would be a good thing. Then it comes to, all right, how do you pay for that? Like, how do you actually get that done? And then you can start to enter into the conversations like, okay, I understand the school is not going to replace the whole HVAC system right now. So let's talk about, can we put in Corsi Rosenthal boxes? Can we use window opening in a strategic way? Can we, have well-positioned fans? Like, let's try to figure out what are the measures that we can do in the time that we have and the resources that we have. And so I would hope that most principals, again, even if they're shutting things down on a COVID front would be more approachable on the, like, how do we get our kids to be doing better on those standardized tests and learning more front, and then let's try to have a partnership where we can all figure out the best way to do that. And again, I'm a huge fan and proponent of the Corsi Rosenthal boxes, which work really well. Publications have shown that they work incredibly well. They're inexpensive, and it's actually a fun school project. I've seen lots of teachers in classrooms with kids above a certain age that do that. You get some duct tape, you put stuff together, you can decorate them with stuff, and it can actually be a fun activity. In the end of the day, you've got, cleaner indoor air, kids have learned a little something about engineering, and everyone is better off for it.
Thank you. I just want to give the chat the 5-minute warning. If you have any last questions for Dr. Levy, please put them in there. And meanwhile, Dr. Levy, we have a question about if the virus could get into a parked car. So say the car is parked, the windows are closed, but if you're inside the car, you can smell smoke sometimes that's outside of the car. So is it feasible that potentially the virus could get into a parked car?
I mean, feasible, of course. I think it's all a matter of, what is the magnitude and the concentration that would get in. And again, I think you're right. I think that the cigarette smoke intuition is a pretty good one, right? If someone is smoking outside, you might be able to smell it, but you're certainly not going to be able to smell it as much as if they are in the vehicle with you, or if you had the window rolled down. So you do have, some physical protection there. Those windows are pretty well sealed for aerodynamic reasons. And so, I do think you do have some degree of protection. Would you want a COVID positive person with their nose pressed against your window, blowing on it for an hour? No, you would not. But, if someone is passing by, you've got the windows up, and it's really a momentary thing, I think you could feel a bit more comfortable with, again, the windows up and, being in your car and feeling reasonably safe.
How are MERV 13 filters for mitigating COVID? Are they really adequate? It seems like that's all we have easily available, but isn't that from the time that we were assuming that the virus was transmitted with droplets? Don't we need HEPA level filtration to combat an airborne virus?
I mean, MERV 13 does a really good job of removing COVID, even right in the airborne phase. The virus doesn't exist naked in the air. It is agglomerated onto other things. And so it is in the size range that, MERV 13 can pick up. Of course, higher MERV rating can remove more. And so if your system can accommodate it, that is wonderful. There are a lot of systems where it won't accommodate it, that just the amount of resistance that creates in the system is just too much, especially if you have a somewhat older HVAC system. So, I mean, I think often the recommendation is put in the highest MERV rated filter that your system can reasonably accommodate without causing significant strain and problem on the system. So, again, I think MERV 13 is, I don't want to call it the bare minimum, but it's certainly a level that works well. And if your system can have more, then by all means, more can certainly provide greater protection.
A question about hiking. Is there a safe outdoor distance? So if you're going to briefly pass by someone, you're holding your breath within 10 feet, is there like a safe distance outside to be around other people?
I mean, again, outdoors is really orders of magnitude safer than indoors, just as a macro statement. There's no magical number. I know we all got kind of locked onto the 3-foot rule and the 6-foot rule and all that. There's no magical number. I do tend to think that if you're hiking and you're just passing by someone on the trail, that is a very, very minimal risk situation. Again, it's, exposure is about, intensity and duration of exposure. And so a fleeting, moment passing by someone, especially outdoors where the air is dispersing, not recirculating, again, very, very minimal risk. We are a very mask utilizing family. we love to go hiking, and we do not wear masks when we're hiking, and we are enjoying the outdoors. Again, if we were hiking up to a place where there are then 500 people all gathered at the top, maybe that's a different story. But on the trail, I think that's a pretty comfortable setting that one could have.
So kind of similar question, same vein. If you're driving in a car and you have your window open, is there any risk if, say, someone passes you on the opposite side and their windows are open? Or is like a motorcycle goes one way and you're going the other way? Is that any kind of a risk, or is there enough dispersion from being outdoors and also being two moving vehicles?
Yeah, I mean, I'd consider that pretty close to zero risk. I mean, both because of the duration, which is less than a second, and as you know, when you're driving in a car, the air is zipping by and pushing along. If there was someone COVID positive on that motorcycle, the air that they are breathing is probably getting nowhere close to your car. It's probably a half a mile down the road, and if that person a half mile down the road, that parcel was coming along, it would have dispersed kind of far and wide by the time it gets to you. So, and to the comments in the chat, right? Again, there are always counterfactual examples, and there are certainly cases where there has been outdoor transmission. I would not say that, you can do whatever you want outdoors and there's no risk of getting COVID, but it's a far lower risk setting. And again, I think the higher risk is you're having an outdoor picnic with someone and sitting with them for an hour versus you pass by someone for a second. I think it's all about, again, intensity and duration and the combination of the two.
Even thinking about, during COVID, downtown, I was living in Minneapolis, they offered a lot of like high intensity interval training workout classes in the park. So they're thinking, okay, we're going to not be in the gym, we'll do a HIIT workout in the park, but you still have people fairly close together who are sweating, jumping around, kind of sharing air for an hour. I would imagine that scenario, being outdoors, is riskier than, say, you go for a hike and you happen to walk past a couple of people on the trail while you're there.
Yeah, exactly. Again, an hour with someone that is breathing heavily is different than a second with someone who is just zipping by. And
Right.
Again, I think the comment in the chat is really important. Again, for any of these things, it's not a 0-1. It's not that we can say these are the sets of things where you will always be safe and you're guaranteed never to get COVID. And these are the situations where you're 100% guaranteed. Like we're talking about risk reduction strategies. The intrinsically riskier a setting is, the more of those strategies you need to put into place so that you can get to a level where you can reduce your risk as much as possible. And so that, really the best we can do with COVID, or really with anything in life.
Right. It's lovely to think that we could get it down to a 0% risk if we did all the right things, but sometimes we're mitigating it by 10%, sometimes we're mitigating it by 50%. The end of the day, we're really just trying to get our risk as low as is reasonable. There is certainly things that we can always do a little bit better to reduce that risk a little bit lower. So thank you so much, Dr. Levy. I'd like to be able to give our group a break before we get to our final session, but I'd like to give you the floor for a few minutes if there's anything further that you'd like to share with our audience that you feel we haven't touched on, or just anything that you'd like to share in general.
No, I mean, I think we really covered the bases well. I mean, I'm again, if there's any sort of bright light at the end of the tunnel here, it's that there is increased awareness of the importance of indoor air, which I think many of us have been advocating for a long time, even pre-pandemic, thinking about the fact that this is where we spend most of our time. This is where we're exposed to most of our air pollution, most of our viruses. And so now that we have this increased awareness, it has to move to action. And I think there have been probably too many times in recent months or years where the action has been vague guidelines and stop there. Like, we ought to have cleaner air, or we really encourage everyone to do stuff. And so that's better than nothing, but not enough better than nothing. And so I think we have to move to the next level, which includes, indoor air quality acts at the state level. It includes individual parents, tenants, building owners, whoever else articulating the importance of indoor air quality, making the case from a health or economic or well-being perspective, and just continuing to push that forward on as many fronts as possible. If people are more likely to patronize a business that provides good indoor air quality than bad indoor air quality, businesses will start to realize where to make investments. If your measure of quality of a school district as someone is going to buy a house includes test scores which are affected by indoor air, but also some understanding more broadly of the state of the school buildings and the ability to have clean indoor air, adequate temperature control, and so forth, again, that will provide the incentive structure for school districts to spend money there versus other places, or for hopefully federal funds to flow so that lower income communities can have the necessary resources. So I think, we all in our communities and in our various settings just need to keep advocating for healthy indoor spaces that will help those who are most vulnerable. It'll really help everyone across the society. So, thanks for having this gathering and for all the people who really have a lot of interesting and thoughtful questions on these topics.
Yeah, thank you so much for being here. We really appreciate all of the expertise you've given us. I know this is your second webinar with us, so we really appreciate having you out here. Folks, we're going to take about a 10-minute break. When we come back, we're going to be talking with Michael Bailey. He's the founder of the Indoor Air Care Advocates, and we're going to be talking about clean air, helping kids in classrooms, and how parents can advocate for their children to reduce transmission of airborne viruses. But if you are childless like me, I'm sure there's going to be some insights from him on other clean air advocacy that we can discuss. So please stick around, and we will be back in about 10 minutes. All right, welcome back, everyone. We are thrilled to have Michael Bailey here to present with us, and I will hand it over to Julie really quick to introduce Mask Together America.
Hi, everyone. As founder of Mask Together America, I am excited to see all of you here at the Q&A session with Michael Bailey, founder of Indoor Air Care Advocates. A school shouldn't be a petri dish. We all know that clean air helps keep kids in classrooms. Tonight, we want to talk about how parents can advocate for the children to reduce transmission of airborne viruses. COVID-19 is a leading cause of death among children and teens, studies show. Healthy children can also get very sick from COVID-19 and other viral infections. It's shocking to learn from a study that some children, 50% to 90%, can pass COVID PCR tests with their cases undetected. That's why children are viral factors in household transmissions. Lots of studies have confirmed that too. And children can get long COVID. 1 in 6 kids have persistent COVID symptoms 3 months after infection. That's another study shows. Unfortunately, it takes time and money and great effort to improve ventilation system in buildings. While we know that roughly 41% of school districts in the US need to update or replace the heating, ventilation, and air conditioning systems in at least half of the schools, which is roughly 36,000 buildings. Much of the $550 billion allotted for ventilation modernization in schools is sitting untouched in most states. Now I will pass the mic back to Sarah Cahill, who is the coordinator of Mask Together America, to begin the Q&A session. Thank you, Sarah, for hosting for us.
Thank you, Julie. Distinguished guests, it is a privilege to introduce our esteemed speaker for today's Q&A session, Mr. Michael Bailey. Mr. Bailey is not only a dedicated advocate for healthier air in schools, but also a co-founder of the Indoor Air Care Advocates, a grassroots organization led by parents committed to championing improved air quality in educational settings. Please join me in extending a warm welcome to Mr. Michael Bailey, whose dedication to creating a better future for our children is truly inspiring. So I'm going to start by giving you some questions that were fielded from our internet audience. And meanwhile, those of you in the chat, please put your questions for Michael Bailey in the chat, and I will pass those on to him during the session. felt like I was doing a great job facilitating this session, and I realized I gave Michael's questions to Dr. Levy, and luckily they were very similar topics. So I'm gonna just kind of do the best I can here with some other questions for you that our internet audience was asking about. But luckily you were both air care quality people. So our top question here is, I desperately want mitigations for my child's school, but my school says it's not necessary unless it's a fire safety issue. What can we do?
It's a difficult question. Do you mind if I address three things from earlier,
Absolutely.
just to tack on some? Yeah, CIDRAP did show that 70% of household spread originated with kids attending in-person school. So that supports what you're saying, Julie. And then also, you said that 41% of schools need HVAC updates. I think I also read from the Lancet that 87 out of 100 schools that in a particular study were not meeting mechanical code. So they may not know or think that they need an upgrade, but they need at least a testing, adjusting, and balancing, which is something that can be asked for by parents. And then lastly, it's often said that ESSER money is untouched, but some people who are in the know are aware that many schools have obligated that money in an attempt to spend it, but have not been successful in getting that obligated money spent. And in Alabama, that creates a potential opportunity for you to speak to your state Department of Education, and we have, and to ask them to help schools that are not able to spend the money they thought, the way that they thought they were going to spend it, to maybe direct that towards portable HEPA filters or getting a ventilation assessment for each school. So while the schools may say the money is obligated, if they have difficulty spending it, that's one opportunity. But to the question about the school where there is a refusal to move, I would say there are kind of a lot of things you can try to do. It depends upon your energy, right, and spoons that you have left. But one thing is to let other parents know what was said, and that's kind of a matter of being a part of maybe the PTA group on Facebook for your school, or trying to find other groups where people talk about their concerns for the school and letting them know, what you said and what the school said, so that you're not the only person who knows about that. That's helpful. Another thing to do is to speak at a Board of Education meeting. And I hope I'm not telling you things you've already tried. I would feel bad then. But speaking at a Board of Education meeting, especially if they're recorded and streamed, that can cause other people to see your battle. And when they can see you fighting for this and they can see the school rebuffing that or giving it lip service, that may help you find other parents who are also noticing the trends. There's, in Madison City Schools in Alabama, which is the school system that we're zoned for, a father on June 6th went to the Board of Education with a public comment of 3 minutes to the effect that he has 5 kids and he routinely sends them to school sick because of the onerous absenteeism policies and truancy policies, and that he has gotten together with other families and an educational attorney and is challenging the school's right to request doctor's notes. That guy doesn't know it, but he's an air quality advocate. So we really have a lot of parents seeing the fact that there's increased illness, and they're just trying to bear that burden by sending their kids to school, which I think I heard one person call presenteeism, which is where you send the kids anyway, but they're not really as there as they would like to be. They're sick. So other things you can do are writing to the Board of Education and the superintendent, inviting the press. So in some cases, we've gotten the press to speak with the school and ask them questions, and that has had varying levels of effectiveness in different school districts. Additional things you could look into are whether the school has had a testing, adjusting, and balancing report or a ventilation report, ventilation assessment in the last, usually you'd say 5 years, but since 2020 was a big event for ventilation, maybe you'd ask, in the last 3 to 4 years, have you had one of these? And if they haven't, that might be the thing you can lobby for to make sure that they work on ventilation and do something to make sure that their systems work. So those are some things. Also, I have to plug the parent guide. We wrote a parent guide that has more things in it that parents can try to locate other parents and to mobilize and activate parents, and also to find ways past the difficulties and the kind of like pushback that we're seeing. And it's not all going to be effective all the same way in all the places. You're going to have to push in different ways potentially. But one thing we're doing is just never giving up. We just know nobody's going to come riding over the hill and do it for us. So we're going to find a way, one way or the other, whether it's through finding out if the Division of Construction Management has authority and jurisdiction to enforce mechanical code, or whether finding out whether the fire marshal might have the authority to enforce code. That is the case in some places, but in some cases with respect to some things, and in other cases with respect to others. So it just depends on your fire marshal and their familiarity and expertise and the law. So anyway, that parent guide can be had at, you can go to our website, iaqadvocates.org, and click the join link, or you can go to tinyurl.com/better-school-IAQ. So that was a long answer. I hope that helped.
Just to clarify, you said tinyurl.com/better-school-IAQ.
Yep, and you dropped the link just right. That was exactly
All right.
right.
It's in the chat. It didn't link for some reason, so you'll have to copy paste it and not click it, but that should be it.
Yep. That's it.
Heather also put in the website for iaqadvocates.org in there as well. So as Michael said, if you click on that, click on the Join Now button, you should be able to access that. Perfect. Thank you, Michael. Thank you, Aaron. All right. So yes, Michael, I apologize. These are not going to be quite the same questions that we thought we were talking about, but they're very similar. So one of our readers wanted to know, is there a way to measure the quality of air to prevent sickness in a space? Do we have a level that is considered safe?
Yeah, that's a complicated question, and there are partial answers. So one partial answer, which I disclaim that this would be the whole story, but this is generally a big part of the story. You can use a carbon dioxide monitor to measure the CO2 concentration. Some of the devices are fairly expensive. The Aeronet 4 is often sold for $249. Right now, I believe there may be a sale for $169 on Amazon, unless my information is out of date. But there are also more affordable monitors. If you're able to look at the monitor, which a student would not be able to, they would be busy studying. But if you're in a workplace scenario, you could look at a Vitalite. I think it's called Vita Light, like vitamin light. I'm not really sure, but those are $40. It's a keychain CO2 monitor that, to my recollection, has a non-dispersive infrared sensor, NDIR, and that NDIR sensor is a higher quality sensor than some other sensors, and so you can usually get a more accurate reading. So anyway, if you bring one of these into a place, what's a good reading? That's the real question, right? And I'm going to also talk about how these are not the whole story, but prior to 2020, mechanical code was the only game in town. And for mechanical code for schools, if we're talking about international mechanical code, which is adopted by very many states, that would be 10 CFM of air per person, and then some more CFM, cubic feet per minute, for the area of the room. And if that amount of air is coming in, and you have a bunch of students come into that room, that should keep the CO2 level not increasing beyond, I'm trying to show you the number that's on my screen, but it won't work, but it should keep that number at or below 1100. And that number, you'll want to know where I got that number, because if you cite that number to a school, they'll say, well, where are you getting that? Potentially, they might not actually know this. So the place where I got that number is UC Davis and the National Energy Management Institute. They produced a video that is short and sweet and informative and talks about carbon dioxide levels and testing, adjusting, and balancing. And so if they were meeting code, it shouldn't exceed 1100. But in October 2022, the American Society of Heating, Refrigerating, and Air Conditioning Engineers, which is a mouthful that I try to get out really fast, but ASHRAE said standard levels of code aren't going to cut it. They said it is standard levels of code are significantly lower than recommended for infection control. And they said there's disagreement over what the right level is, but there is broad agreement that standard levels are far too low, significantly lower than recommended. After that, they came out with a standard called ASHRAE 241. And that standard says that when you have a public health reason to mitigate the spread of illness in buildings, then you can exercise what's called infection risk management mode. And I'm certainly not a professional to be able to expound on this in great detail, but what I collect about this is that instead of implementing just mechanical code, you would then elevate your ventilation and filtration to 40 CFM per person. So that would mean you'd be giving, you'd have a CO2 reading that would be about 650 parts per million if it was all outdoor air. but it's so expensive for schools to condition that much outdoor air. In some cases, they can't do that. And so they might use filtration. And then this sensor wouldn't really tell you anything about that air cleaning. So one of the things that we have to do is develop relationships with our schools and, both all work from a place of collaborative and earnest care and effort to make sure that we're all on the level about how to achieve these filtration rates so that, even though we may not be able to measure it as parents, we would be able to trust that, the school is doing as they said they would, and they're following these standards. So that's one of the most aggressive standards I know of. Prior to that, though, the CDC said that 800 parts per million is a decent limit for ventilation. So if your school is just using outdoor air, you should expect somewhere between 800 to 1200 parts per million just by meeting code, actually. So I could go really on, and I shouldn't. But if anybody has a follow-on question, I'll answer that question. That'll kind of retrain my focus.
Well, I was going to say, just to expand for our listeners who may not know, my understanding is the AirNet is testing the CO2 levels in the air. But if you were using a filter, it's not necessarily going to be able to tell that those are clean CO2 particles versus viral-laden CO2 particles.
I see what you're saying. Yeah. So you're hitting on two things, I think. One is that if you're filtering air, that won't filter gases like CO2 because, it's not going to trap in a particulate filter. So that's number one. You won't see it change in this number because you're using filtration. And number two, if you do happen to see a number that's bad, it is worthwhile to wonder whether there is filtration at work that might mitigate that risk that you don't know about. Commonly, though, schools don't tend to have that. Many schools still have MERV 8 filters. The schools that have given it some effort have at least moved up to MERV 11, and that's great. MERV 13 is one of the core recommendations of the ASHRAE Epidemic Task Force. And so a lot of us have been saying to schools, can you please install MERV 13 filters? But some schools will say that the pressure drop from that filter is too aggressive and it's going to freeze the blower or cause some kind of destruction. And they're not wrong. If they don't shop the market to find filters that have a low pressure drop and are MERV 13, they may not find a filter that can actually work with their system that is a MERV 13 filter. And when that's true, experts have said you should at least pursue a MERV 11 filter. Although there is we have information in our slide decks and presentations that is for facilities managers to try to find more data and information from the experts who have written about finding filters with higher surface area or other properties that allow them to be MERV 13, but not have a wild pressure drop that would make them unusable. But yeah, to answer your question, you won't see filtration reflected in this. The best way to have filtration as a parent and know about it and be aware of, like, for us to have a measurable, provable thing that we all know is happening, is to advocate for portable HEPA filters to be in the classroom. And that happens to be one of the main things that Bill Banfleth said when he wrote to the Alberta chapter of ASHRAE. He said, your HVAC, even if you install MERV 13 filters, it's not likely to meet recommendations. And so you're going to need to supplement. And one good way to supplement is to use portable HEPA filters. And what I've learned from reading studies and from looking at the market is that putting one portable HEPA filter in the room is still not going to usually meet recommendations because you can't crank it all the way up. It'll be too loud and the teacher will come and turn it off. So you need it at maybe half speed or what have you. And then you generally would need another one in the room. And the other thing is to try to look at the cubic feet per minute that they put out. And I mean, we could talk in great detail, but you want it to be a significant amount of clean air. So I'm open to follow-on questions, but I don't want to dig too deep into a rabbit hole that people are not wondering about.
Sure. Yeah, I was thinking like TLDR, if you had two rooms and one of them had 1,000 on your AirNet, but no HEPA filter, and the other one had 1,000 on your AirNet, but it did have a HEPA filter, you would still prefer the room with the HEPA filter because you would know at the very least there's some amount of filtration happening there and it's not going to be reflected in the AirNet. But yeah, that might not be a point that needs to really be brought up to this audience. So still good to talk about these things. Sure. Laura from the chat wanted to know if a classroom has a window AC unit and there's no mechanical ventilation otherwise, is that going to bring in enough outside air to warrant not having a HEPA? Sounds like this is what's going on with her school, and they told her they'd get back to her, but that sounds like it might not happen. So
The question is, what is enough? And so that ends up being a question that we can answer with many different answers because there is a diversity of standards. On our website, we've documented many of the different experts and what their recommendations are, going all the way back to explaining what the units are and how the units may relate to each other so that it can be understood by people who have not been studying this for a long time. And so I think that can be helpful for you to get familiar with what units are available. CO2 monitors are one of the most readily available things that parents can use to monitor what actually is going on. And so if we're looking at outdoor air and we're looking at what's enough, I would say the bare minimum would be the weakest recommendation as far as I can discern in a classroom by numerically comparing them. And that would be 800 parts per million of CO2, which coincides with 20 CFM, roughly, depending on how old the students are, about 20 CFM per person. That is the minimum that I feel is doing right by students because it adheres to the CDC's 2020 recommendation. And that is also the same recommendation as the United Kingdom's Scientific Advisory Group for Emergencies. And it is also very apples to apples with the World Health Organization's recommendation of 10 liters per second per person. They all are roughly very close to the same, assuming students are not doing jumping jacks or anything in class.
perfect. Thank you.
Did I answer that?
I had a question from the internet about the effectiveness of masking in a setting like public schools. So this parent basically said her kids go to public school, they ride the school bus. She's not so concerned about in their classrooms if they're masking there, but like the school cafeteria, they're having to unmask there. In the buses are very crowded. She's kind of thinking, is that an effective place to mask if they're having to take their masks off to eat lunch?
Yeah, that's rough. There's a lot to say there. So I'm not a certified industrial hygienist, but I've read what certified industrial hygienists have said, which is that if you're wearing a respirator, you can get roughly 90% of the particles that are coming at you to be caught. And if you're wearing a surgical mask, it's roughly 50%. And if you're wearing a cloth mask, it's roughly 25%. There's also a study from Argonne National Laboratories that says that if you wear a hybrid cloth mask, you can get better filtration than a single layer loosely woven mask. But you'd ideally want something like a respirator. And for kids, that might be like a flow mask or something like that. As far as whether it's effective when you have to take it off during lunch, it depends on the circumstances, like whether they're near somebody who might be a source and how much outdoor air is coming in to diffuse that and reduce that spread. So air quality in the cafeteria might be the first thing to wonder about. You might, in fact, want to send a CO2 monitor mostly to see what the air quality is in the cafeteria. And if that air quality isn't, I shouldn't say air quality because air quality is manifold and involves many, many things more than just carbon dioxide. What I really mean is, if you want to find out what the risk level is, you'd want to know about the outdoor air that's being introduced. And one way is a CO2 monitor, like we've talked about. So an example that you can work with would be if you bring that CO2 monitor in and they're meeting code. Maybe they are meeting code and it's 1,100 parts per million. That means they're limiting the amount of the rebreathed air fraction that everybody's breathing of everybody else's air from their lungs that have come out of their exhalation to about 2%. According to a blog by Dr. Alison Biles, which is based on a spreadsheet by David Elfstrom, which is based on science by a person who I can't remember the name of. But basically, that means that every 50-ish breaths, you would be inhaling a full lungful of the air that's been inside of the lungs of the people around you. So certainly not great. That's why mechanical code isn't enough. But it's not unexpected to find that. If it were above that, then if the CO2 were above that, then you're rebreathing more air. And so there's a greater likelihood that stale air will linger with potentially active virus particles or influenza or what have you. And then, that could get into the airways and you could inhale that infectious dose while you're eating your lunch. So air quality there is important. And then if they were observing the CDC's 2020 recommendation and they had 800 parts per million in the cafeteria, that limits the rebreathed air fraction to 1%. So it'd take 100 breaths to get a lungful of the air of the people from around you. Of course, in reality, it depends on how close they sit together and so many other things. But having proper air quality there would be a big deal. I've also heard that UV is an effective solution. There's recent science to say that UV does have some byproducts, but there's also been the suggestion that it might be an okay trade-off if there's proper ventilation to remove those byproducts, and if the exposure is limited, such as lunch rather than being all day. And that's kind of like, I think it's an unresolved question whether that trade-off is okay for society. But I think that that's one of the few places where I would say, yeah, put UV in the lunchroom, please. The problem with UV as an advocate for me, though, is that I've really not found an apples to apples comparison where I can tell school administrators what the key figures are to get a UV setup that's going to equate to a certain amount of filtration. There certainly are studies that have correlated certain configurations to certain effective air change rates or equivalent air change rates. But I just can't seem to hone in on the key figures that you, as a facilities admin, would need to know to make sure that you're telling the vendor that you require it to meet that air change rate. They could, of course, specify an air change rate, but then how do they verify that? What I'm really seeking is something that they could use a radiometer and be like, oh yeah, it's meeting that key figure. And so I know I'm getting the effective air change rate I thought I was. But I really haven't gotten that kind of surety. So I don't tend to advocate specifically for UV. I can't support doing it in a way that we can verify that it's doing what it's supposed to, even though I know it can be effective.
Thank you. Irina would like to know, and I know this may not be your direct area of expertise, but if a student were immunocompromised, does that mean that a college or a school could require a classroom to mask as an ADA accommodation?
I think that the World Health Network has put out some really good information, and Shay O'Neill is working with the World Health Network as part of the schools task force, and she has supported putting out some information about 504 plans and or IEPs. And I'm not perfectly acquainted with these topics. Like I've had to use them actually briefly, and I just haven't become an expert. But you could go to that information at the World Health Network website. I think it's WHN.global. And you also could get in touch with, and I learned this from a WHN podcast or an event that I was also speaking at, but I learned it from one of the other speakers. You can look up the policy and advocacy, or I'm sorry, it's protection and advocacy organization for your state. These are federally funded and required to exist in every state, and I believe territory in the United States. So P&A groups are capable of helping you navigate 504 plans and IEPs, I believe. I might be misspeaking on IEPs. But IDEA and Section 504 are education-related regulations that may be of use. The other thing is that if you do try for an accommodation and you're rebuffed, the Department of Education's Office of Civil Rights, or OCR, is a place where you could write a complaint for discrimination. And that is exactly what I would do if I had an immunocompromised child. That child has standing for me to write that complaint and pursue what I know is right by them.
Ross would like to know, what sort of questions do we need to ask custodial staff about the central HVAC system? We're told that it's set for 6 ACH and it's fitted with MERV 13 filters. Do we ask for more purges? Do we ask for CO2 monitoring? Some funding's available from the municipality, so with your help, we're hoping to lobby for better quality air in our classrooms. And thank you.
Yeah, thank you for the question. I would say that my first order of business would be verifying that the 6 air changes per hour is occurring as they think that it is. And there are a couple of pitfalls that they might not be aware of. And so this is one reason why having a collaborative, respectful, civil relationship with our schools is important, right? We're not shouting people down at board meetings. We're trying to be productive about it. So if you have that, if you can foster that relationship where everybody knows that we're all working from a shared purpose of keeping kids safe and healthy and in class, you might be able to ask them, is it all from outdoor air or is it filtration? And if they indicate that filtration is helping them achieve the 6 air changes per hour, you might ask them to look at Wade Conlin's spreadsheet, which is called the Equivalent Outdoor Air Calculator. I'm going to go find it. I found it, and I will link that in the chat. Wade Conlin is an instructor at ASHRAE, and he created a calculator that can be used to quantify the contribution of filtered air to the total equivalent outdoor air. And what we're talking about when we say equivalent outdoor air, this is a term that I've heard through ASHRAE and other presenters, essentially, and experts. There's outdoor air, which is the real thing, and then there's out air that has an equivalent level of contaminants as if it were outdoor air, but it isn't outdoor air. It's just filtered or otherwise treated for IAQ. And so that spreadsheet that I just linked gives information that your facilities administrator could use to quantify how much equivalent outdoor air is coming from that MERV 13 filter, in order to help make sure that that they're accounting for all of the good stuff that those filters are doing. I find that a lot of schools kind of put MERV 13 filters in, and I don't think that they know to quantify what that's contributing. And so I think that it might be encouraging for those staff to look at that spreadsheet and understand that this goes towards the level of clean air that you're achieving. It's not visible on a carbon dioxide monitor, but if you're using MERV 13 filters and your fans are on in that school instead of set to auto, which is important, then that air is being treated for indoor air quality by filtration, and that counts towards the air cleaning. So I would just want to get some numbers. I would probably get a CO2 monitor into the classroom, or actually you could ask that facilities administrator if they would be willing to, or ask your teacher if they'd be willing to put a CO2 monitor in the room. Don't have it under anybody's mouth where they're breathing. Don't have it under a diffuser where fresh air is coming in. Don't have it by a window. Just maybe put it on the desk as long as the teacher's not speaking onto the desk. And then you can measure the CO2. And then from there, you can estimate based on the number of occupants. And you can certainly get in touch with us at Indoor Air Care Advocates, and we'll point you to some resources that are based on the Harvard T.H. Chan School of Public Health. They did an awesome presentation, and they put out slides. And Rhode Island made a spreadsheet based on that. We've made a spreadsheet based on that. You can basically compute like an estimated amount of airflow. And then if you know the room dimensions, you can begin to see like, are they really getting 6 air changes, or were they mistaken? I find that a lot of admins are doing a tremendous job, and they're under the impression that they're achieving certain metrics, but sometimes we find out that they're not. And it is to their surprise when we show them what the readings are in the room. And it's an opportunity for education. I think we need to be sure to give grace. Like people are being asked a lot of right now, like they're getting hot calls because the AC isn't keeping up, or they have bus issues and so on and so forth. So everybody's learning. And so we need to be supportive of schools. And hopefully if we encounter that new and surprising information, find a way to work collaboratively towards rectifying it. Filtration is certainly one good way. I would just say, get in touch with us if you could, if you're doing that. We'd be happy to support the number side of things. Yep.
Heather would like to know, as an advocate, you've advocated for engineering controls, but you still wear a mask even in places where you know the ventilation is good. Why is that?
Yeah, good question. So I wear different kinds of masks depending on what it is. But usually indoors, I will wear an N95. Oh, you can't see it because I'm blurring my background. Let's stop blurring the background and you can take a look. There we go. This is a 3M Aura N95, and this is an Envo elastomeric half mask with ear hooks. And depending on the situation where, for comfort or for other reasons, I might choose one or the other. But the idea is that I'm going to go get a hyperlink. I'm going to paste it in here. The American Council of Government Industrial Hygienists say that a cloth mask has about 75% inward leakage and outward leakage. Surgical has about 50% inward and outward leakage, and N95 has 1 to 10% inward and outward leakage. And the reason why I would wear one of these in a place where I think there might be good ventilation is because here's an example. I take this CO2 monitor to the grocery store all the time, and I've discovered which grocery store I want to go to based on that. One of them has abysmal air quality. The other one is Kroger. And so at Kroger, I still wear a mask. Because if you hold this thing all the way through the store, you'll get to the front of the store and you'll find that there's a pocket of increased CO2. And that just means that people are breathing in that area and it's diffusing, but it's not diffusing out fast enough. And so you're kind of in a pocket of other people's breath. You're always in a pocket of other people's breath. The CO2 is representing how thick that stale air is. But I just, I can't see aerosols, respiratory infectious aerosols. I can't know if somebody was just standing here hacking a minute ago and whether that's still hanging. And if SARS-2 hangs in the air for 3 to 6 hours, as I know it does based on the DHS calculator for airborne decay of COVID or of SARS-2, if I know that, then I know that I don't want to walk through a cloud of that. So I wear one indoors at all times.
That makes a lot of sense. Let's see. Derek would like to know if portable HEPA filters might solve some problems but create new problems if not carefully placed. He basically cites the CDC's fan guidance that fan discharge should be directed towards an unoccupied corner and a wall space or up above the occupied zone. You shouldn't use high-speed settings, and you shouldn't, or you should minimize the potential to create air patterns that flow directly across one person onto another. Would this apply to portable HEPA filters as well?
Yeah, it's a good question. I'm not the professional engineer to answer this question, but I'll tell you what I've absorbed from listening to professional engineers speak, and that is that you don't want air to be pointed right at somebody and then passing from them to somebody else, because what can happen is called entrainment. This is the mechanism that I know of that can be harmful, and there may be others, but and it could be drafty and uncomfortable for the student. But if you have air passing by an area where maybe somebody is a source and that air is moving fast, it creates a low pressure zone, and then the other air around it gets sucked into it, and so the clean air begins to mix with the air from that source, from that maybe that person who is sick, and then that airflow of clean air is now carrying particles along with it that are infectious aerosols. And so if you point that at somebody, you could be distributing, just depending on chance, you could be distributing that infectious aerosol along with the clean air. And then when it hits that next student, that's a problem, because then they may be more likely to get sick. And so it is preferable it's certainly preferable to meet the guidelines and recommendations that are made by these experts. And so if you have a HEPA filter, ideally, you don't want it pointed like right past some students and into some other students. You do want it to be, ideally, if you could, have a portable HEPA filter that's pointing at the ceiling. That's pretty ideal, because that creates good mixing, and that means that clean air that is coming into the room is not going to I shouldn't speak beyond my depth. My understanding is it creates good mixing to have it pointed up. So I'll leave it at that.
Thank you for that. Julie would like to know some of the reasons why you co-founded the Indoor Air Care Advocates.
Yeah. Oh, so this goes back to the first question that you asked me, which is, what do you do if your school isn't doing anything? And what we chose to do was acknowledge the fact that other parents are going to experience this too, and then reach out and form a web of parents to try to find the schools that are doing something. And this has worked, actually. Huntsville City Schools is an example. That's a neighboring school district where we briefed them in January about what we knew, which is the same briefing that we gave to that healthcare organization with long-term care as their interest. And we shared what we knew, and later they let us know that they were exercising a program from our state to get free HEPA filters. And they observed the recommendations of the Center for Green Schools, which is one of the sources that we shared with them. And those recommendations were not to exceed 50 decibels. So I think that kind of back to the most recent question too, one of the other harms that you might introduce would be noise, right? You don't want to have these things cranked all the way up. You may indeed need to run them at moderate fan speed so they're not so noisy that faculty can't tolerate them. So that's why we founded it. We knew that we couldn't be the only people running into this. Huntsville, Alabama, they have so I was responding to the chat. I should make that clear, but somebody said Huntsville where? And that's Huntsville, Alabama. So Huntsville City Schools got 2 MA 112 Medify Air purifiers, and they have them in the rooms, 2 per room, and the faculty are instructed to run them at fan speed 2. Or they should be instructed to run them at fan speed 2 if they received the handout that specifies that. And that handout is also educational. We helped co-produce it, and it has some good information about why we would bother to use HEPA filters in classrooms. If you want to know more about that story, you can go to our website, iaqadvocates.org, and go to our blog. And it's maybe the second or third or so blog in our, if you scroll down.
Perfect. Thank you. We wanted to ask you too about when poor air quality affects health and increases the risk of transmission of sickness, is it possible to have indoor air quality regulated in schools?
Can you repeat the question?
Thinking we know that indoor air quality affects a variety of things from sickness to transmission, and knowing that there are standards out there, is it possible that we could see regulation happen to get air quality at a certain level universally?
Yeah, so there are multiple answers to that question. One answer that you can exercise right now, depending upon where you live, is some states have different authorities that can exert lawful means to compel schools to meet code, or to compel certain spaces to meet code, or to meet certain other laws. And I would like to take a moment at some point to go find the information where you might be able to find that. I think that I have a source that might cite a source that I might be able to share about that. But essentially, it sure is a patchwork and it's difficult. And one of the problems is that most of those standards that I'm talking about are really kind of pre-pandemic standards, before we had a new way to get sick that might magnify the impact of other illnesses by possibly suppressing immune response. And I, just so that people know why I'm saying that, in case people aren't familiar with those possibilities, Ontario Public Health put forth an evidence brief in June of 2022, right before the triple-demic, incidentally, that said that SARS-2 could have an immune dysregulating effect, and they couldn't predict what kind of impact that might have on hospitalizations and viral load, viral burdens in the community. And then right after that, Ontario's hospitals really did get clobbered, just like Alabama's and many other places in America, with the triple-demic. And after that, there was information to say that, well, there was a study, I should say, to say that children who had COVID, a history of COVID, had a 40% greater likelihood of needing to receive medical attention in a hospital for RSV, a totally different virus. So I'm not a public health person, so I can't perfectly interpret all these studies, but they do seem consistent with that. So what I'm saying is, all those old standards were made before we had a challenge like this that was disrupting our attendance, disrupting our normalcy, and getting in the way of our productivity and happiness. ASHRAE said in October of 2022, those levels are not adequate to meet recommendations for this new challenge. And so even going to the agencies that may be able to compel schools to meet code or what have you isn't ultimately enough. It's certainly something that's worth doing if you have that lever to pull on, because schools ought to be at least doing that for kids. And we have had ESSER money for a great long time and great information about it. And so it's a reasonable thing for you to request and demand. But it's not actually enough. So beyond that, yeah, there have been people working on getting the recommendations to be the rule. An example is in Illinois, a group that I guess I would say is connected with us, called Illinois Stakeholders for Air Quality in Schools, put forth legislation with the help of a legislator, and it is HB 3713. And that went through the House, and right now they are renewing their work on getting that passed in the Senate. And the point of that would be to require a certain amount of clean airflow in classrooms, in addition to making sure that ventilation assessments occur on a regular basis and that there is monitoring taking place in the rooms. It's a really strong law that we, strong body of legislation that we wrote testimony in support of, because that would be a great step forward for Illinois and for America to see a state that does something about the problem proactively, that is not a half measure and not marginal, and is more likely to then be effective. So yeah, I hope there's a future. I expect there'll be a future where we can expect to meet those recommendations in schools and workplaces and public buildings, because it's unfortunately, it's just what is needed if we're going to see normalcy again.
Thank you. And I apologize for putting you on the spot with that one, but you handled it really well. So appreciate that.
No worry. Thanks.
Derek wanted to know if you have the study handy that shows that the 87% of schools don't meet mechanical code.
Yeah, it wasn't that 87% of all schools don't meet mechanical code, but it was that, and I'm struggling to get it because it's one of the older releases from the Lancet that cites a study, but it was that 87 out of 100 schools studied in a certain study did not meet code. I'm going to go to the Lancet Commission's website, and if you'll bear with me.
Meanwhile, last call in the chat, if you have a question for Michael. We're coming up on the end of our session, so we're going to get at least one more question in, but if you have anything else you'd like to say, make sure that you drop that in the chat.
I'm going to have to punt on this because I can't locate it. It's normally really readily available when I go to their website, but now I'm finding a whole lot of other things. I'm like, what are these? So for the 87 out of 100 schools, well, if you can get in touch with me at indooraircareadvocates@gmail.com, that's indooraircareadvocates@gmail.com. I'd be happy to turn that out for you.
Thank you so much. All right. So Elsu was asking, go ahead.
I was also going to say, it is really good that you're asking, if anybody's asking where something is from, that's because, hopefully because when somebody challenges that this is a fact, you can cite the source. So it's always good for us to know, like, just because Mike Bailey said something, that might not really be good enough. What you really need to know is like where that source came from and where that study was and all that. So I applaud your assiduousness at citing the real source and having that on hand to maybe learn more about it. So.
And I have not been to your website yet, but do you have resources like that cited for parents to bring to schools if they need them?
We cite a lot of references in our blogs where we talk about the recommendations and the science that has turned up to tell us what happens when we meet those recommendations. It is very much the way that we have cited those sources is really to support that what we're saying is not, something that we originated. It's not that we claim to be the experts. It's that we are pointing to what the experts and the scientists have said. And so it isn't like a resource bank. It really is more like citing sources when we make assertions that we claim to be factual.
Perfect. That's very helpful. Thank you. Elsu would like to know, she read if there were plastic partitions put in at the beginning of COVID. They were trying to prevent droplet transmission. Did that actually increase the risk for infection depending on the airflow?
I've heard that those can create eddies and other aerosol phenomena that might concentrate bioaerosols rather than actually protecting from infection. And moreover, the fact is that both the WHO and the CDC have at one point or another said that it was airborne and then retracted it. And then, later on, kind of after the Lancet Commission put out their 10 scientific reasons why this is likely to be airborne, both organizations ultimately did accede that it is airborne. But prior to that, harm was done because we treated it like it was droplet spread. And then this is kind of my interpretation of what I saw. So, you may have seen something different, but I saw that people seemed to lose faith in public health measures because we were applying the wrong ones. We were applying droplet and fomite public health measures to an airborne virus. And what we should have, in my opinion, is an armchair quarterback of public health, right? Which I try to not to be, but in this one, it's inevitable for me. I think we really should have treated it with the utmost caution and assumed it was airborne until proven otherwise. And it just didn't play out that way, and I think that harmed our response. And so plastic barriers, I don't know how much they may have harmed us, but I know that they very likely didn't help us based on what I've heard from aerosol scientists.
Thank you so much. This seems like a good question to end on. Ross would like to know, what's the best way to mobilize our collective resources to most effectively see changes to air quality in schools and institutions?
That's a hard one because parents are so busy with so many things. And one of the things that I think might help actually is that they often are busy collecting doctor's notes for their children who are sick. And I think that if you can find opportunities when parents are venting about that to say, hey, let's look at the reasons why that might be. Can you imagine a world in which schools didn't have to be a petri dish? There's information to say that if we pursued these recommendations, we wouldn't have quite the same burden of illness to deal with, and we could go to work and have our paid time off be used for something other than being sick all the time. So use that potentially. But it is hard. Parents have so much to do. Some of them work multiple jobs and they have kids going to school, but then they also have extracurriculars. And so it's hard for parents to want to put that much energy into something. And so sometimes you have to find the few who understand the issue with you and are also fired up at the injustice of it. Because the reality is that there's been really good information for a very long time, along with lots of money. So it's hard for me not to be a little upset that we have yet to do right by kids and bring them back for the safe return to schools. I often, when I'm feeling cynical, will put scare quotes on safe return because really the most important recommendations weren't done. So finding parents who are fired up about the justice aspect of that, and or parents who are upset and fed up with having the elevated levels of illness that we are seeing. I think that those might be ways to get parents to understand the importance of the issue to their lives. Otherwise, it's hard to engage because parents have just so much to do. But reaching out, I'm almost to the point of going door to door at this point because I think people need to know. It's a lot of work, though. Either way.
Thank you so much. I just want to give you a couple of minutes at the end here if there's anything that you want to soapbox about or anything that we didn't effectively address. The floor is yours.
I should have thought of something. No, I would just say I think that a lot of the questions here have been spot on. Normally I would say, well, we haven't asked the right questions a lot of the time, and that we haven't asked for quantifiable answers from schools. But a lot of the questions in this bank were really, how do I quantify? How do I ask the right questions? So they were spot on questions. I think parents are getting wiser to what's going on. A lot of the recommendations have said things like to the extent possible, or, as best you can, basically. And that really lets people off the hook to say, oh, we did the best we can, so we're ready for school. And it's like, well, that's not really a good enough recommendation. We've needed quantifiable recommendations. And that's why Indoor Air Care Advocates has been really focused on highlighting and centering those quantifiable recommendations and highlighting and centering how they were validated by experts like ASHRAE, who say that standard levels are just so far below what's recommended. And then making it clear, like, if we don't meet those recommendations, I don't think that we can expect to have, pre-2020 levels of illness and absenteeism and other things. Another thing that I think is worth asking, just an open question, really. Why don't we have reasons for these absences? I know that there's work associated with getting reasons for absences. And so I just think it's time for us to say, well, if chronic absenteeism is a black box, I think we need to illuminate it and make it not an opaque issue. So I think we need to try to find ways to espouse policies in school districts that would turn up some reasons for these absences. The only study I know of that I can point to that says the degree to which illness is a factor in absence is the Central Texas Absence Reasons study by the E3 Alliance in 2015. And in that study, acute illness, was far and away the number one reason why kids didn't make it to class. It was 48% of the reasons. The next highest was skipping at 5%. So that's a factor of 10 for sickness versus other reasons. So I don't know, I know that 2020 changed people's habits, and I know that illness, sure, it can't be all of the problem, but certainly if pre-pandemic absences were 50% attributable to illness, then we could still claw back some attendance if we reduced illness, even if that illness isn't new, which I think that many of us would agree that there is a new and increased amount of illness. So I just think that that's worth pursuing, getting reasons for illness and pointing to the fact that, EPA and other groups have found significant increases in attendance when we ventilate above what we previously were doing. So there are just so many plain old good reasons to do it, like just the health of kids who have asthma and teachers as well. Asthma is the number one reason for chronic illness to produce absenteeism. And in the Central Texas Absenteeism study, that was number 3, chronic illness. So we have number 1 is acute illness. Number 3 is chronic illness. And the number 1 reason for that is asthma being triggered by, I'm guessing, poor air quality or irritants in the air. So we just have so many reasons to do right by kids and make sure they get healthy air. I guess the last thing I would leave you with is that we need schools to understand that the instructional environment is essential and foundational to the learning. You can't. I've heard it said actually by. I'm not sure if she said this on the record, so I'll just say I've heard it said by somebody who I very much look up to, and I've been following information from quite a bit. But basically, the buildings are part of the curriculum, and I take that to mean you're not going to learn anything if your building is hostile to occupancy, right? If your building has things in it that make it hard to make it to school, that curriculum isn't going to land. So I think that schools need to look at it that way and understand you're not going to get from point A to point Z if in between we drop off in the middle because kids can't show up to school because they're sick. And I also have noticed a lot of articles that don't take it at face value that kids could be sick. I see many articles that say parents have been conditioned to keep kids home at the slightest illness. And I think that that's not taking at face value that those kids may be ill. I also see articles that say that teachers called in en masse, called in sick, and that it was suspected that it was the union. Now, I have no inside information, but I think another reasonable hypothesis might be that they were sick. I mean, we are literally right in the middle of an uptick of SARS-2, and the CDC just issued a health alert indicating that RSV is on the rise in the Southeast. So I think it's reasonable to guess that the faculty could really have maybe been sick too. But I don't perfectly know that situation. I just noticed that illness has heretofore been a big reason why people don't make it to work and to school. So there's no reason to expect that that's not happening now, and no reason not to do something about it. So I think I've taken too much time. So I appreciate your generosity.
You're perfect. Thank you so much for being here. I know that we've seen recently that I think 75% of household transmission starts with a sick child. So really, by advocating for clean air in schools, that has a ripple effect on the entire community. So we really, really appreciate all of the work that you're doing. And we appreciate you taking the time here tonight and sharing all of these wonderful resources with us. So once again, folks, I would direct you to visit the Indoor Air Care Advocates website, the iaqadvocates.org website, to get resources and information for your local community and share it with any parents that you know who might be interested. And we really appreciate having you here, Michael. So thank you so very much.
Thank you.
Julie, is there anything that you want to say to wrap us up for the night?
Thank you for hosting this event. And I know, what we have gone through from yesterday to today, your hard work really show, and we really appreciate you. And also the rest of the team and all the great audience for being here, participating and putting all your questions in, and inspiring all of us to come together and continue to work hard. And it really shouldn't be a dream to see our administration to take the action and do the right thing. But right now, this is a dream, and we'll have to continue to make noise, and we have to continue to take action together. And we, Mask Together America, invite all of you to join us. And just, I'll drop our email address here. You can write to us and be a part of our campaign. We're always looking for volunteers. We're all volunteers. So that's what it is. And follow us on Twitter, Facebook, Instagram, and Threads.
And we have a Facebook group called Mask With Us. I dropped the link a few times in the chat, but it is Mask With Us, and that is our private Facebook group where we discuss masking and other COVID precautions. Thank you so much for being here. We look forward to seeing you again. We're going to have another webinar next Thursday with Dr. Robbie Tamargo, and that is going to be at 6 o'clock Eastern Time. So please come join us for that. Thank you so much for being here, and have a wonderful